is case reviews for Clark County, February 2022. As always, this information is confidential and privileged under the HIPAA law or act, in that any use, distribution, copying is strictly prohibited. And moving forward with case one. So case one is a 69-year-old male who was reportedly playing bridge with his wife. The call was for altered mental status. PPE usage documented included a HEPA mask and gloves, no indication for eye protection. This was late last year, so we were still in our pandemic. Primary surveys that the patient was awake, his airway was open, and he was protecting it. Pulses were present, there's no active bleeding. In that vital signs took more than 10 minutes after patient arrival, so I'm not reporting it under initial assessment. The patient was documented to be 102 kilos, and that his only past medical history documented or reported was vertigo. The story, I believe, was provided by his wife, who had stated that he was playing cribbage when he suddenly developed altered mental status after looking away or gazing away, and that this occurred approximately 15 minutes prior to EMS arrival. The call occurred at 17:10, so I started putting into treatment the initial time that patient contact was made, so that we have an idea of if there might have been overnight, early morning, what other factors you can consider. So at initial patient contact at 17:10, blood glucose was noted to be 106. BFAST was performed. A 12 lead was also documented as being performed, but it wasn't uploaded into the chart. Otherwise, I would include it here for your guys' review. In that, a LAMS score was assessed. They documented as a 5 for LAMS, and then an IV was established. They initiated transport 8 minutes after patient contact and for a stroke alert. They noted that he was listening to his left. He wasn't responding to commands. His left upper extremity appeared to have a drift. He had a left facial droop, and he had difficulty with speech. Per the documentation in the chart, it stated that he showed major signs of possible stroke in nearly all categories. And interestingly enough, they did document that his fingers were cold, noted to be attributed to poor perfusion. 12 minutes into this encounter, the patient's SATs were determined to be 82%. It wasn't previously documented, so I don't know if he was always hypoxic. He was placed on 4 liters nasal cannula, and an IV was established. A second IV was established. 13 minutes into it, a full set of vital signs were obtained, noted to have a heart rate of 55, a blood pressure of 162/138. I suspect that that might have been inaccurate given the small pulse pressure differences. Respiratory rate was documented as 18, and his GCS was 12. Even despite nasal cannula application, his subsequent pulse ox was determined to be 77%. A second full set of vital signs was obtained with a heart rate now of 83. Blood pressure is now 111/83, and a respiratory rate of 12. His GCS has remained the same at 12. In that he arrived to the hospital 30 minutes after patient encounter. I'm just checking to see if Dr. Hoskins is on this call. I don't see him in the guest list. So the good regarding this pre-hospital presentation and care was scene time was minimal. If you remember, 8 minutes. A blood glucose was obtained, a BFAST was assessed, a LAMS score was assessed and documented, and that the hospital destination was appropriate for concern for a large vessel occlusion with a LAMS score greater than 4. A 12 lead was documented to be obtained. Make sure that you upload them, and that an SpO2 was obtained and oxygen was given due to hypoxia. And 2 IVs were also established due to concern for the patient's acuity. And then
also, Jackie, also last known well or last known normal was established.
Absolutely. That's absolutely. I was going to say that basically every stroke alert. Sorry, I'm going to stop talking while my copy machine is working.
One of the hazards of being able to do everything on online.
Sorry, it won't be that much longer. So as you guys are already aware, but as a reminder, since 2021, we've been reviewing, maybe it's going to stop. Since 2021, we've been reviewing all stroke and STEMI cases. And so if any of our cases are either determined to be a stroke or a STEMI or suspected in your primary or secondary assessment, I'll review them and you'll be getting notifications if we fall out for KPI, key performance indicators for the state of Washington. So just as Dr. Whitwer mentioned, last known normal is also an important KPI measure. So this documentation for possible stroke met all of the KPIs and would have passed. Where we could do better is that if eye protection was used, we need to document that and uploading a 12-lead EKG. I don't remember specifically what I was mentioning about the documentation. I think it probably had to do with making sure you upload your 12-lead. So in the emergency room, the first set of vital signs for this patient, heart rate of 78, blood pressure of 90/47, respiratory rate of 31, and SATs of 94%. There's a little bit of conflicting documentation regarding his aphasia. Expressive aphasia is that the individual would understand, but they can't speak, and receptive aphasia is they're able to speak well, but they can't understand. So maybe there was waxing and waning of these two aphasias. They noted that he wasn't following commands, is neglect because he wasn't acknowledging one side of his body. And his NIH stroke scale was 23 as a measure to understand how high that number would be. A range for an NIHSS is 1 to 42, so pretty profound. Most of the time, our stroke alerts come in under 10. So this guy had quite a high stroke scale for what he was presenting with. He was upgraded to a neuro 911. Neurology via telemedicine was contacted, and after verbal discussion with the doc and the neurologist, the plan was to prep for TPA. He went to the CT scanner to get a CAT scan of his head and the blood vessels of his head and neck, and they identified that he actually has a type A dissection. Let me see if I can pull these. Yes?
Of what?
That's what I'm pulling up here in a second. Can you see my screen?
Yes.
Okay, so let me make sure that all the audio. So the first picture or the first video I'm going to show you is a CT angio of the aorta. First I think it'd be easiest to go through just an image, the whole video. So to get you kind of oriented here, your heart, your liver, I believe that's going to be a stomach, and then his aorta. So remember that your aorta branches off of your heart, your aortic arch comes down through the thoracic, kind of mediastinal, and then comes down into your abdominal aortas, and then branches in your pelvis until your iliacs. So normally a CAT scan dedicated to the contrast of the arterial or the aorta should show contrast fully distributed throughout the lumen of the aorta. And you can see this patient's contrast isn't fully dissipated throughout his vessel, and that represents an aneurysm here. This would be the darker portion here would be the dissection flap, and the contrast portion is the true lumen. So I'm going to play it again, now that you kind of have a reference of what you're looking at. Following, not distributing contrast, kind of a tortuous aorta aneurysm. And as you come off, you can see the aortic arch up here having a dissection extending. So his type A dissection, which will be part of the discussion in subsequent slides, extended from his aortic root down to his right common iliac artery. The dissection flap extended into the right brachiocephalic and left subclavian artery, leading to significant occlusion, as we'll see in the next video or the next image set. He did have perfusion to his celiac, his superior mesenteric artery, and his bilateral renal arteries, given that those were the ones supplied by the true lumen. They also thought that there was, and we'll see here in a second, the right kidney they thought might show some evidence of an infarct. So right for orientation is on this side with liver. So here's your kidney and just maybe not consistent contrast of uptake. And then the second one is a CTA of the head neck. What I wanted to point out, so remember, we're looking right is the handedness to this CAT scan and left is over on this side. And you're looking for basically symmetry for the most part. So this is a contrasted study dedicated just to the arterial vessels of the head and neck. And so for the most part, you should see symmetry. So that's the key point as we look at the common carotids. We see contrast here and nothing on this side. So severe occlusion, stenosis to the right common carotid based off of this dissection with substantially reduced blood flow, especially to the proximal portion, but allowed for, they calculated about approximately 80% stenosis secondary to the dissection, allowing for blood to perfuse more proximally. So once it was determined that this patient actually had a vascular catastrophe, TPA would not be indicated. He developed AFib with RVR. Cardiology or cardiothoracic surgery at OHSU was contacted regarding this patient's findings with plans to transfer to OHSU due to his needs exceeded the PeaceHealth's ability to take care of him. They recommended that blood pressure goals should be for a systolic approximately 100 and to get him get him over to OHSU as quickly as possible. They had told, speaking with Dr. Hoskins, which I don't think he's still on this list, he was told that this patient should not be intubated as they didn't think he would survive intubation, but to avoid intubation at all possible. His blood pressure started to drop, and although they were trying to balance keeping his blood pressure low, but also not too low, given that we want to make sure that perfusion to the end organs would continue to occur, he was given small amounts of phenylephrine. At 50 minutes into this case with the hospital, his SATs dropped substantially down to the 80s. He was placed on a non-rebreather, but unfortunately, he did not have significant improvement in his saturations. They prepped for intubation. They gave his RSI meds, and I believe in speaking with Dr. Hoskins that he had placed the laryngoscope blade in the mouth and the patient arrested, so he boarded any additional intubation attempt and started to resuscitate him using half-dose epi, trying to prevent further propagation or rupture of his dissection. After 2 rounds of ACLS, they were able to achieve ROSC. They intubated him without additional RSI meds, in that he again arrested with even the placement of the ET tube and the laryngoscope. So again, they gave half-dose epi at 0.5 milligrams, and he developed ventricular fibrillation. They were able to shock him out of it, but his family arrived, or where the discussion was undertaken with the family, and they said that he would want to be a do not resuscitate goals of care. So when he rearrested, they pronounced him. He did not transfer. Any questions, thoughts before going into this type of condition? All right. So you guys may have remembered, oh, sorry, someone had a question or thought? No. So you guys may have remembered, I think about a year and a half ago, we presented a case of a 39-year-old with chest pain and back pain, and he also had a dissection. So this is a little bit of a review, but incidence of aortic dissections is up to 30 cases per 1 million people per year. Black descent is more likely to have this condition than white. And there's a higher propensity in male individuals as opposed to females. Almost 70 or majority of these cases occur in patients aged 40 to 70 years old. And that the pathophysiology regarding this condition is that there's 3 layers of the vessels, especially our large vessels, and that there's separation of the layers within the aorta. They're further categorized by either Stanford or DeBakey. This image on the right-hand side shows you that if you were using the DeBakey classification, it would there'd be up to 4 different classifications: type 1, type 2, type 3A, and type 3B. I believe I'm more familiar with the Stanford classification, which is type A and type B. Type A dissections involve they're considered ascending aorta. So as you can see in this image, the true lumen and then the dissection with the propagation of a false lumen or blood outside of the true lumen, starting at the aortic arch and potentially dissecting all the way down. But these 2 images here are type A or ascending aorta dissection. If the dissection doesn't involve the aortic arch, such as image here and image here, it's considered a type B dissection. It's pretty important to, at least in like the definitive care realm, to determine what type of dissection the patient has, because the treatment could be vastly different. So ones that usually require surgical intervention are going to be type A dissections, complicated type B dissections, and type B dissections that are actively bleeding or any unstable patient, where type B dissections, those not involving the ascending aorta, are all usually medically managed if the patient is stable, so no need for surgical intervention. The mortality rate for this type of condition is up to 30%. And then these patients will usually present with acute pain. 85% of them will, and that depending on where the dissection is occurring, that will be the location where they might be complaining about pain. I spoke with the nurse taking care of this patient, and I believe, ultimately the patient had complained of kind of chest pain throughout the day, but didn't really pursue further, but had spoke to his wife about it. Scary enough that 15% of these patients will present with absolutely no pain complaints. They might have jaw or neck pain, can be confused with potentially like an MI or chest pain patients. They might be short of breath if it's involving the aortic valve or leading to heart failure. There's usually vital sign abnormalities depending on how severe this condition, usually hypertensive, although if there's active bleeding, there could be hypotension as well. Pulse deficits are present approximately 31% of the time. And then again, if the dissection extends proximal all the way to the aortic valve, you'll hear a murmur of the aortic regurgitation murmur. And that depending on where the dissection occurs, if it's involving the aortic arch, potentially the subclavians or the common carotids, these patients might look like a stroke up to 40% of the time, and some patients just have anxiety or impending sense of doom. Risk factors are going to be patients that have congenital narrowing of their aorta, such as coarctation of the aorta. They might have they likely will have underlying atherosclerosis, so it's why the age group is usually the much higher individuals, like the 40 to 70-year-olds. Hypertension history, if they have a bicuspid aortic valve, and if they have a weakened aorta, such as with like our Ehlers-Danlos patients, the congenital tissue abnormalities. And then just a kind of an idea is that, as mentioned, the pain might be located, may change depending on where the location of the dissection is, but why these patients can present in a vast particular presentation from anywhere from back pain, chest pain, stroke, heart failure, new murmur, stuff like that.
Okay, you're back.
So going into our Southwest Regional Protocol Review, I searched for dissection. I think Dr. Whitwer's speaker is still on. Mark, are you able to change that?
Yep.
If he can silence and then he can unsilence. So when I searched for dissection in our protocols, the only place where it came up was for syncope. So it's a good reminder that our syncopal patients will need to be considered for a differential diagnosis of a dissection. But as for management, we don't really have any place in our protocol that talks about management. If you have a patient that you have a suspicion for a dissection, I would prepare appropriately, let the hospital know, come in code 3, have 2 lines. If you want to talk about if there's any pre-hospital management, that would be a phone call to online medical control, because these patients, we do not want to just deal with their blood pressure. Because they are likely to have rebound tachycardia. So if you think that you're helping them by lowering their blood pressure with the only agent that we have, which would be nitroglycerin, that you might actually be making things worse for them by causing them to become tachycardic. So these would be online medical control, appropriate notification, and IV access. Does anybody, I don't know, if Dr. Whitwer is still busy, or I don't see Dr. Mock on this, but any questions or concerns, thoughts about this patient before moving on to the next case?
Oh, I'm still here. It looks like the crews did perfectly on this. I mean, this presented as a as a profound stroke, and that's what they dealt with. They did not do anything for the initial hypertension, which seemed to resolve itself.
Yeah. Absolutely. All right, so moving on to case 2. This is a case of a 71-year-old male. EMS was called for a breathing problem. PPE usage is at maximal protection, in that the primary survey was that this patient was awake. His airway was open, but he was labored. He was tachypnic. He was in a tripod position. Pulse was present, but there was no signs of active bleeding. Vital signs were obtained 8 minutes after patient contact. Noted to have a heart rate of 90, a blood pressure of 211/115, a respiratory rate of 30, GCS of 15, and room air sats of 90%. He was a 100-kilo individual. His past medical history, either obtained by his meds or from history taking, was that he had a history of COPD, coronary artery disease, previous stroke unknown if he had previous deficits, hypertension, hyperlipidemia, AFib, and currently on Coumadin. And that the history that the patient provided was that his shortness of breath started 30 minutes prior to arrival. This patient was placed on a non-rebreather early into contact with him. They noticed that his breath sounds were diminished. He was anxious, and it's documented that he had broken sentences, which I would say would probably meaning that full sentence dyspnea or 1 to 2 word dyspnea. He was started on a bronchodilator in the form of albuterol and Atrovent 5 minutes into this encounter. They noted that in their documentation, they said that his room air sat initially was 86%. They placed him on a neb and that he went to 94%, which isn't reflected in the vital signs, but that's fine, at least in this presentation, and it's fine to explain. So his sats improved with the bronchodilators, but they said that he was still tachypnic and labored, so they prepped him by pulling out CPAP. As they were assembling CPAP, the patient reported that he was claustrophobic and he couldn't tolerate it. The vital signs, as previously mentioned in the subsequent slide, he was not tachycardic, he was hypertensive and tachypnic. An untitled CO2 was obtained in 10 minutes after patient contact with a value of 38. And he An IV was attempted at 14 minutes, which was unsuccessful. A blood glucose was obtained from that, which was 137. And at 17 minutes, they noted that his stats had further declined despite the interventions to 78%, and his end tidal was 25. They gave him at 22 minutes 25 milligrams of IM ketamine to sedate him, and they got a subsequent set of vital signs that showed now a heart rate of 100. Blood pressure was not taken. His respiratory rate remained at 30. His sats were 84%, and his end tidal was 20. It's documented that Fire attempted to coach the patient. He was ripping off everything per documentation, including high flow nasal cannula. So they had to back off the nasal cannula to 3 liters and titrate it up as he would tolerate through coaching. It doesn't appear from the documentation that he was ever actually kept on a CPAP. Transport was initiated at 28 minutes. They noted that at 31 minutes that his SpO2 was 100% and his end tidal CO2 was 11. And that because he continued to be very anxious, they gave him another 2.5 milligrams of IM Versed so that he could tolerate the interventions that they were attempting. They did document that they were prepping for RSI in the event that his mental status declined or his stats declined, and they arrived at the hospital at 40 minutes.
Well, was there blood pressure taken after that last one at
Only one blood pressure was taken.
215 over 115?
Yeah.
Mm-hmm.
Yeah. So great segue into where we are talking about things that could be good and bad. So oxygen administration, recognizing that the patient's breath sounds were abnormal and intervening appropriately. They noted that he wasn't wheezing, but they were diminished, so they attempted bronchodilators. They documented that they wanted to start him on CPAP, but it was complicated by the patient's ability to cooperate. IVs were attempted. They coached the patient to help him tolerate the non-rebreather mask since he wouldn't tolerate the CPAP, and that they prepped for backup airway equipment in the event that he had a precipitous decline. Where we could improve is that past medical history. So past medical history would have included that he has a history of renal failure on hemodialysis and had missed dialysis. As for his chest exam, documenting if there was symmetric bilateral chest rise, and then dosing of ketamine, as we'll talk about in the next couple slides. Our documentation of ketamine, or our protocol for ketamine, doesn't currently include IM dosing. Absence of serial vital signs, so only one set of blood pressure, one obtainment of a blood pressure, no 12 lead, and potentially talking about tunneling down to bronchodilator distress or COPD exacerbation, and not recognizing the full picture of that. This patient appeared, at least in one number, to be quite hypertensive. In the emergency room, it was determined, so I assumed that this patient had some kind of catheter or access, so even if he didn't provide that history, the physical exam would indicate that he was getting dialysis. So he reported that he dialyzes on Mondays, Wednesdays, and Fridays, and that his last run on Friday, he did not fully dialyze, and it's currently Sunday, so he's approximately 2.5 days from his incomplete dialysis. He also noted that he had dietary indiscretions, stating that he wasn't following salt or water restrictions. First set of vital signs upon hospital arrival is that his heart rate's 90, his blood pressure is 164 over 91, his respiratory rate is 26, and his SpO2 is 100. What draws my attention is that both pre-hospital and hospital, he only had one heart rate of 100 despite his profound shortness of breath. So that would get me to ask why is that occurring? This patient was on beta blockers, but the history that he provided the emergency room was that he took an extra dose of metoprolol because he thought his shortness of breath was due to his AFib. His initial gas showed respiratory acidosis with a pH of 7.15, and his CO2, which is synonymous for the end tidal CO2 that we monitor, was 72, so he was retaining. They did a bedside ultrasound and noted what we call B lines, but which are usually pathognomonic for pulmonary edema. So confirmed by bedside ultrasound that he likely had significant pulmonary edema. He was placed on BiPAP. IV was established, and he was given 20 milligrams of IV ketamine. A nitro drip was started. He was also given bronchodilators and simultaneously treated for COPD exacerbation with Solu-Medrol. They were able to stop him off the nitro and remove BiPAP prior to admission to the ICU. And his chest X-ray showed diffuse pulmonary edema. He underwent urgent hemodialysis, and according to the documentation, they believe his pulmonary edema was renal-mediated, missed dialysis, dietary indiscretions, and accelerated hypertension associated with it. And he was able to be discharged on hospital day 3. So this is a case that we need to be pretty broad about our differential for shortness of breath and try not to hone in too much about just a COPD history, especially if we're getting a story of a sudden onset, they're hypertensive, and other factors. So, and missed dialysis. So this gentleman, in general, accelerated hypertension is considered any blood pressure greater than 80 and any with a diastolic blood pressure greater than 120 with evidence of end organ damage. End organ damage will be discussed a little further on that history and physical exam, but there's usually 2 cases per million each year, per million patients or people, I guess, per million patients per year or people per year. The etiology is usually related to noncompliance with whatever their regimen is, if that's blood pressure meds or renal disease, endocrine dysfunctions such as like pheochromocytoma or abnormalities with sympathomimetic hormone release, drug use, renal vascular disease, renal parenchymal disease, if there's a history of coarctation of the aorta, some CNS disorders, and if they're non-compliant with their antihypertensives and they're currently in withdrawal from them. It's important to note, and I'm going to say it again here, is that just the blood pressure itself without complaints doesn't make it an accelerated hypertension case. You'll see a lot of our patients that we come into contact with will have an elevated blood pressure, and it might just be related to what they call white coat syndrome or ambulance syndrome, if you want to relate it to pre-hospital, but it's usually transient. It isn't sustained, and they're usually asymptomatic. So it has to be an elevated blood pressure greater than 180 or 120 with end organ damage to be considered this type of emergency. So the blood pressure rises rapidly in a short period of time, and the patients will have complaints that are usually related to what end organ impairment they're having. So if it's a CNS end organ impairment, they might be altered. They might have a seizure. They might be complaining of a headache. If it's affecting the vasculature in their eyes, they may complain of blurry vision or vision changes. If they're having problems such as impaired perfusion to their heart, they might have chest pain, they might have a dissection, so back pain as well. They may be complaining of shortness of breath because of heart failure related to this severe elevated pressures. They might be intolerant of laying flat, and they may be complaining of nausea and vomiting, also kind of a CNS presentation of end organ damage. If you have a patient that you suspect is having a condition of either accelerated hypertension or malignant hypertension or hypertensive crisis, whatever 3 terms that you might use that mean the same condition, you want to check the blood pressure in both arms. And that our goals in managing these patients is to not drop their blood pressures substantially. It's a gradual decline. So we usually look at the MAP and try not to drop it by greater than 20% within the first hour. And then we'll try to decrease it gradually over the next 24 hours. Exceptions to the goal of care for this condition is a patient that has sustained a stroke, an ischemic stroke. So we we treat them with permissive hypertension unless their blood pressures exceed 220s. With the acute aortic dissections, as mentioned in the previous case, we're lowering their blood pressure substantially, but also managing their heart rate because of the pathophysiology of rebound tachycardia. If they have a bleed in their brain, we don't try to lower their blood pressure because we don't want to, unless it's significantly elevated past usually 210, 220, because lowering their blood pressure might impair their CNS perfusion. Or if they have an MI and you're suspicious of a right-sided MI, or they're on a phosphodiesterase inhibitors. This image on the right shows a normal optic disc and a papilledema presentation on the left, so blurring of the disc margins. Doing an ocular exam doesn't happen as frequently as it probably should, but that's a part of the physical exam that would occur in the hospital. So in this particular patient with respiratory distress and has a history of COPD, but if you were also suspecting maybe pulmonary edema given his high blood pressure and his impaired ability to remove fluid because of his kidney failure, the difference here, I'm going to kind of more focus on the E portion here, is that all these shortness of breath patients, we're going to be sitting up. They don't tolerate laying flat very well unless they're impending respiratory arrest. With our pulmonary edema patients, we recommend potentially letting their legs dangle or lower their legs because it helps decrease the amount of blood or fluid back to the heart, or decreasing the I believe I'm having a moment. I was going to say preload, but I believe it's preload. Yeah, not afterload. And then if the patient is an extremis, you're going to be using CPAP with them with 100% FiO2 and using a PEEP, an increased PEEP to help displace the pulmonary edema within the lung bronchioles. Our protocol says if their blood pressure is greater than 110, we're going to be giving nitroglycerin at sublingual doses every 3 to 5 minutes. I would recommend, follow the protocol, but I wouldn't just be looking at a systolic blood pressure of greater than 110. I would be looking at pretty profound hypertension if we're thinking about treating pulmonary edema. And then use caution if there's a suspicion for a right-sided MI, or if they're on Viagra or Cialis or any of the other phosphodiesterase inhibitors. Any other questions or thoughts?
Was there any reason that they did not use this case to me is pretty obvious. First of all, the patient was hypertensive, had a cardiac history as well as COPD history. If it had been any higher than that, I would have thought that this was a perfect case of flash pulmonary edema with hypertension. And I know that they didn't have an IV in him with a systolic pressure of over 200 and a diastolic pressure in the 120 range. There's absolutely no reason to not give them nitroglycerin sublingual.
Yeah, and that's what I was kind of getting at with the tunnel vision, is that just looking at it as a reactive airway exacerbation, where this patient is suspicious for decompensated heart failure, acute heart failure because of his hypertension.
Well, I suspect that there's another tunnel vision in that I think, because I've talked to a few of the crews, and they think that that they shouldn't give them nitroglycerin if they can't get an IV in the patient. Well, that's true. You shouldn't give them nitroglycerin if they're hypotensive or if they have a right-sided MI, but you can give them, even if they have a right-sided MI, you can give them nitroglycerin if their blood pressure is 212 over 130.
Yeah, no, it's a good point. And I believe in 2017, there was a study that came out looking at do we really cause hypotension in right-sided or inferior infarcts, and the kind of the warning of don't give nitroglycerin to those patients. That coronary geography would be potentially disastrous they found that the data didn't really bode out that that was the case. It was more of be cautious, but don't necessarily prevent that treatment.
Yeah.
All right. Case 3 was a 27-year-old female, estimated motor vehicle crash, rollover, single vehicle. So EMS was called for an unresponsive party. PPE usage was maximum. Primary survey is this patient was unresponsive. Her airway was open, but she wasn't protecting and she was having agonal respirations. She had a pulse, but some bleeding from her chest, but no concern for hemorrhage. Vital signs were greater than 10 minutes with the transporting agency's documentation, so I'm not including it. And then the fire department was able to get vital signs, or at least some vital signs in the first 4 minutes of patient contact, noting that her heart rate was 110 and her respiratory rate was 6. Unknown history for her, given that she was unresponsive, and no reported bystander. Although later in her hospital course, it sounded like she was the passenger and that the driver had caused. Anyway, so there might have been somebody on scene that could have given additional information. The vehicle that the patient was in was traveling northbound on I-5. It was a single vehicle rollover. Presumed that the patient was unrestrained as she was found approximately 75 feet away in the median of the highway. This occurred at 23:27. She was placed on a 15-liter liter per minute bag valve mask. Was also an I-gel was placed, which she was tolerating, and she was given an. I'm a little bit confused about the oral pharyngeal in I-gel, but maybe the oral pharyngeal was placed first and then removed, and the I-gel was placed, or it was actually an NPA. Nonetheless, 2 minutes into this encounter, spinal precautions were obtained. They did a rapid trauma assessment, noting that she had a closed right forearm fracture, suspected closed right forearm fracture, in that she had a laceration over a right clavicle without any arterial bleeding. An IV was attempted at 8 minutes and at 9 minutes, which were both unsuccessful. At 10 minutes, she received 100 milligrams of IM ketamine. Although a set of vital signs wasn't obtained prior to the IM ketamine by the transporting agency, for all intents and purposes, her GCS was never high. I don't think it was at any point even higher than 6, but all of the GCSs are documented as 3. In speaking with the paramedic who gave the ketamine, the justification for giving the ketamine at the 10-minute mark was that although her GCS was low, if there was any level of consciousness, the presumption would be that the patient would be in pain, and that since they were planning on RSIing her, they thought that treating her pain and sedation with a large megadose of IM ketamine would be appropriate. We'll talk about that in future slides. So full set of vital signs showed that she was tachycardic at 118, blood pressure of 121/70, and her respiratory rate was 6. Her GCS was 3. She had a SAT of 93% with the I-gel, and her end tidal was 58. Transport was initiated 14 minutes after patient contact by transporting agency. I believe it was actually 17 minutes from initial patient contact by both EMS agencies. So greater than 10 minutes for our full trauma guidelines, although I know we've talked about potentially making that less than 20 minutes. But so transport was initiated and IO was placed. At 18 minutes, she received 5 milligrams of Versed and 50 micrograms of fentanyl, and then she was intubated after getting 90 milligrams of succinylcholine. All of these meds were through the IO. The intubation was unsuccessful, citing that the paramedic student had a lower skill, in that they were also using an inappropriately sized ET tube. Another set of vital signs were obtained, noting that she had a heart rate of 116. Now they got a palpated blood pressure of 120, and that they documented her respiratory rate as 0. Her GCS remained the same, and her end tidal rising at 71. Another attempt at intubation 4 minutes later. with video laryngoscopy and a bougie that was later successful when they exchanged the bougie with a stylet and placed a 7.0 E2 tube. She got post-intubation sedation, 100 milligrams of ketamine through her IO, and she arrived at the hospital 32 minutes after patient contact with a heart rate of 86, a blood pressure of 100 by palp, a respiratory rate documented as 0, SATs of 98%, and tidal of 55, and she had received another 100 micrograms of fentanyl and 5 milligrams of Versed. So early spinal precautions, stabilizing her airway with an eye-gel, doing a rapid trauma assessment, and then determination appropriately for full trauma with appropriate hospital destination and serial vital signs. The patient was on scene for greater than 10 minutes, so determining where we can improve, determining what's most important for this patient. Is it managing their airway or scene time? Are you managing this patient's airway adequately, even with a supraglottic airway? And would staying on scene further really help this patient or not? In this particular case, I believe that given that she was ventilating and oxygenating with an eye-gel appropriately, there would be no reason to delay transport to place an ET tube, especially as her underlying problems were multi-system trauma, given her mechanism of injury. After the rapid assessment was performed, a good detailed assessment would be indicated, and that would particularly with the complaints of extremity injury, ejection, and clavicle injury, it would be a good neuro exam, a good chest exam, and a good pulmonary auscultation exam for this patient, which was not very robust in the documentation. Monitoring the vital sign trends, so not just getting serial vital signs, but also noting that there's abnormalities. The patient remained tachycardic, but the blood pressure started trending down, and also that her end-tidal CO2 was also trending up. The use of ketamine in this particular case, our protocol doesn't indicate that we should be using ketamine. This particular case occurred prior to induction with ketamine, so that has since changed, but we shouldn't be treating patients with a GCS of 5 or that we actually can't assess their pain level, just empirically treating them with ketamine. And we shouldn't also be deciding that, well, if we have an indication for pain management with ketamine and we could potentially sedate them for post-intubation sedation, that we should just combine the dose and give them a mega dose. That's inappropriate and outside of our scope. And as for the intubation with the patient, like our field training or our precepting paramedics should be ensuring that all of our students are going to have a lower level of competency, so guidance with that student, and also making sure that they have the proper equipment, because you might only have one check or one view, and that after that one attempt at intubation, any potential subsequent ones would be worse. One of my pet peeves is documenting a respiratory rate of 0 when that indicates that we haven't been ventilating this patient for 10, 15 minutes. So I would document, and I would suggest that we document what the patient is being ventilated at. If you want to document in the narrative that the patient had no intrinsic respiratory efforts or was over-breathing the ventilation, that's fine, but you're documenting what we're providing to this patient. And this patient, yep.
Jackie, I agree with all that. I must have drifted off there a second. What did you say about this occurring before we're using ketamine for induction?
So no, this was before. I'm sorry. This was before we agreed ketamine could be a post-intubation.
Okay.
Yeah, post-intubation.
That's not what you said, but that's
post-intubation.
Okay. What came out was induction.
Yeah.
And we've been using ketamine for induction for a long time.
Yeah. So post-intubation sedation.
Yeah.
And then lastly, do we really need to sedate a patient that has a GCS of 3 that you potentially would be able to intubate without without any meds. But
Sure that,
especially as the patient becomes more unstable, that we know our post-intubation sedation could potentially drop their blood pressures, making them even more profoundly unstable. So I think a strong consideration is that we should be thoughtful about, I know it's a fine line that I'm talking about, but we should be thoughtful of that. Maybe we judge if they are becoming more agitated, but thinking about how awake this patient was prior to you RSIing them. What are the odds that if they are unstable, that their GCS has improved further since intubation? So I'd be very cautious about, do we need to give them full doses of post-intubation sedation for this patient? Especially as we're seeing here in this slide that the patient was intubated at 26 minutes, then got 100 milligrams of ketamine at 30 minutes, so 4 minutes later, and then at 6 minutes ends up getting fentanyl, full dose of fentanyl and a full dose of Versed. It seems like a lot of maximum dose treatment for this patient who's very unstable.
yeah, what does she need the Versed for at that point?
Agreed.
And we've not seen any, we didn't see any change from her GCS of 3 at any point. How much did she weigh?
It was documented that she weighed 60 kilos.
Okay, yeah, we should probably have, especially because she was not exactly hypertensive, we probably should have kept her ketamine at no more than 1 milligram per kilo.
I mean, I think the ketamine would be less likely to cause them to be hypotensive.
No, but even
Fentanyl.
post-intubation, we may want to cut. I know we've been using a ketamine dose of full intubating dose of ketamine post intubation for sedation, but I've been doing some more reading, and then we've got the national recommendations now, and I'm suspicious we should probably cut that post-intubation dose down to 1 milligram per kilo rather than keeping it at the full pre-RSI dose.
Yeah, I will talk about that in the next couple slides. And then, yeah, and I'll talk about something else in the previous case that I forgot to mention. So those are my QA discussion for this patient. In the emergency room, she lost pulses shortly after arrival. She received CPR and epinephrine. She had a resuscitative thoracotomy accessing on the left side, and then a right chest tube was placed. There was a gush of air in return of pulses, so they thought that she potentially arrested from a tension pneumothorax on that right side. Large bore lines were placed, and she was started on the massive transfusion protocol with 4 units of packed red blood cells, and she went to the operating room. So that's kind of my concern, is that doing a good detailed exam in the pre-hospital setting after intubation, given that this patient has a probability of having more than one part of her body injured, and especially after doing positive pressure ventilation with either an iGel or an ET tube, being very cognizant about the fact that she could have a pneumothorax that is going to profoundly increase given that positive pressure ventilation. And as her vital signs decline, that should be something that we should be reassessing as, do we need to intervene? In the operating room, she had they identified a moderate amount of blood in her abdomen. She had a liver laceration and a spleen laceration. They removed her spleen and they kept her open with abdominal packing. Her other injuries, after she came back from the operating room, she went to the CT scanner and got some plain films. She had a right subclavian injury, a left radius and ulnar fracture closed. She had multiple thoracic fractures, but specifically an unstable T6, and multiple lumbar fractures, specifically an unstable L3. She had a left femur fracture closed. She had multiple pelvic fractures. She had a right orbital floor fracture. She had bilateral pulmonary contusions. She had a left adrenal laceration. She had 4 through 7 right-sided rib fractures, 1 through 7 left-sided rib fractures. There was, I put right tension pneumothorax based off of her cardiac arrest in the emergency room. And then, as mentioned earlier, she had a spleen and liver laceration, and she also was paraplegic. She had a very long hospital course with multiple surgeries, but she was able to be transferred to inpatient rehab on hospital day number 65. Yeah. So I thought this would be a good time to talk a little bit about ketamine. It's gotten a lot of coverage over the last year, but also because this case was an example of the EMS team stating that, well, I want to treat pain and sedation, so I'm just going to give a mega dose, and recognizing that that is not logical based off of the potential dosing of this drug. So ketamine was produced in the 1970s. It was similar to PCP. The mechanism of action of this drug is that it antagonizes an NMDA receptor. It can lead to dissociative anesthetic, and it also inhibits sympathomimetic reuptake. So that's kind of why you see potentially tachycardia, less hypotension, because it doesn't allow for your sympathomimetic hormones or your epi-norepi to be reuptake, to be broken down. And I wanted to say something else about this too. So when an NMDA receptor is activated, remembering that ketamine deactivates it. When it's activated, it opens the channel that's indicated here in the right upper box. Sodium and calcium is allowed inside the cell, potassium comes out, and that these channels, when they're activated, are responsible for memory formation. So they believe that when they're antagonized or decreased, it impairs memory anywhere from low dosing to memory dysfunction to high dosing, leading to psychosis or complete inability to communicate. So that gives you an idea of why there's different dosing for this drug. Pharmacokinetics on this is based off of ideal body weight. In the United States, there's a lot of less than ideal body weight. So recognize that we're not going to base this off of our morbidly obese patient's weight. It's going to be what would be ideal for gender and height. Onset of action is less than a minute, and the duration is up to 10 minutes if given IV. And then pharmacodynamics, the dosing, the lower dosing 0.1 to 0.3, although it can be up to 0.5 like our protocol, is for analgesic dosing. 0.2 to 0.5 is usually the recreational dosing from misuse. And then the 0.4 to 0.8 is the partially dissociated, which is the place where we want to stay away from when we're dosing these patients for treatment. And then our fully dissociated dose is 1 to 2. In the emergency room or any place that does procedural sedation, we usually start our dosing at 1 mg per kg. So trying to give anybody greater than 0.5 mg per kg dose would be inappropriate for pain control. And I would suggest that maybe we consider 0.3 mg per kg. In this particular case, this patient was given IM dosing. So as we know for IV dosing, that our IV dose is not equivalent to our IM or our IN dosing. And for the most part, it's usually twice the dose of an IV dose to be given IM or IN. So recognizing one, because in the previous case there was the patient with concern for COPD, but also with accelerated hypertension and heart failure, in acute heart failure with pulmonary edema. That male patient got 25 milligrams of IM ketamine, which wouldn't help in trying to decrease the anxiety of CPAP. If that was to be the case, it would be double the dose, and it's not in our protocol, so it would be a call to medical control. So for our dosing, we're really looking at analgesia and for intubation or in the hospital procedural sedation. I'm pretty sure that this is not in our protocol, but I personally try to avoid using it in anybody who already has an altered sensorium, so our schizophrenic patients. So looking at our protocols, ketamine comes up in our CPAP to help with angiolysis for patients that can't tolerate it without some additional assistance. Our dosing is 0.5 mg per kg for a max of 25 milligrams. And then just doing a little bit of simple math on that if we're doing the if we were to try to aim for 0.3 milligrams, then we would be let me try to see. Then we would be looking at our 25 milligram dose. It would be appropriate for anybody over the weight of 183 pounds. And then over on the right hand side, ketamine, just under basically the medication administration. So an induction agent used for RSI, pain control, refractory to standard treatment, but also angiolysis would be another indication. Contraindication is eye pain or trauma, known pregnancy, and non-traumatic chest pain. I'm assuming the non-traumatic chest pain is for a possible aortic injury or aortic pathophysiology. Is that right, Dr. Whitwer?
Yep.
Okay. Side effects is that it could increase blood pressure due to the sympathomimetic reuptake inhibition or inability to the catecholamines being higher with this medication. And then emergence reaction can occur in 5 to 30% of patients. So that's this partially dissociated, but also as they're coming out of it as well. The duration is up to 10 to 20 minutes according to our protocol, in that continued sedation must be provided before the induction agent has worn off with use of RSI. Our dosing is 2 mg per kg for induction. For severe pain, it's 0.5 mg per kg IV or IO. I guess I missed it elsewhere, so I apologize. We do have it as 1 mg per kg IM, which is, remember, double the dose. And then CPAP, it's 0.5 mg per kg IV or IO with a max of 25 milligrams. I want to also point out for our agitated patient management that ketamine is not anywhere in there, so we should not be using ketamine for that indication anymore. So for our patient that needs to be sedated and we think it's related to underlying psychiatric problem or unknown etiology, but we don't think it's withdrawal, drug ingestion, or post-ictal state, we have the option to treat with droperidol and or Haldol, but not simultaneously the two. The max dose for droperidol is going to be 10 milligrams, and max dose for Haldol will be 10 milligrams. If we have an IV, we'll be using smaller amounts potentially than our IM dosing. And then if we think that it's withdrawal, seizure, or sympathomimetic related, we'll be using Versed over either the antipsychotic or droperidol. And then if there's severe agitation or excited delirium, we'll be using droperidol 10 milligrams IM and 5 milligram Versed IM. We can exchange out droperidol with Haldol. That's kind of the major points that I wanted to talk about that. And then remember, for pediatric patients, that this would be the only area that would be using Benadryl as potentially to decrease their agitation. Benadryl should not be used as part of your sedation or your severe agitation unless the patient actually develops extrapyramidal symptoms. Any questions, thoughts, comments, clarifications, corrections? All right.
Yeah, Cliff put a note in the thing that said that protocol changes of January 2nd, 22. Ketamine was reduced from 0.5 milligrams to 0.3 milligrams IV for sedation.
Perfect.
So it's already in there. So if you're going to use it,
It should be 0.3.
yep.
Perfect. I would support that, and I'm glad that we already have it. The problem for me is that our protocol app, I can't upload the most recent version, so I'll try to get a hold of Sean again about that. Nonetheless, so the last case to present is a 13-month-old male. EMS was contacted for a seizure. Both agencies document concern for scene safety. It sounds like that there may have been upwards of 10 bystanders, including family in a small area, an apartment building or an apartment room. PPE usage was maximum. Primary surveys that this patient was unresponsive and thought to be seizing, and that his airway is open and not protecting. He was hot with a palpable pulse, no active bleeding. Vital signs were obtained 1 minute after patient arrival or patient contact, and noted to be a heart rate of 188, a blood pressure of 148/82. Respiratory rate was not taken. SpO2 on room air was 99%, and he was 9.1 kilos. Looking at whatever resource they use, if that's hand heavy or any other type of, or like a Broslo or a PD wheel or whatever device you use to confirm normal and abnormal vital signs, he's a little hypertensive at 148/82. And it's important to get respiratory rate documented if possible. There should be not a lot of reasons that we don't do that. Past medical history, none was reported. And the family stated that he has been seizing approximately 5 minutes prior to contacting 911, that he had a fever today, and that they did not give him any meds. We didn't document how high his fever or if it was obtained, like if it was subjective or actually determined to be high. This encounter occurred at 22:42. I just mentioned to you the vital signs. I'm going to kind of talk about the documentation here. The white one is the white letters are going to be AMR, and the reddish ones will be Vancouver. So just kind of comparing documentation. So AMR documents that they grab Versed, syringe, needle, and alcohol before even entering the patient's house or apartment, and that they document that the initial temperature was 97. So no indication for Tylenol, Versed. The fire department documented that the patient was actively seizing, and once the pediatric resource was pulled up, the patient stopped seizing, and Tylenol was given, no Versed, because of the belief the protocol said only if the temperature is above 103 and if the patient is seizing.
Can I make a correction at this point?
Yeah.
Because the VFD temperature was 97.0, but nobody trusted it. The AMR temperature was taken and was 103.8.
Okay. Yeah, that's what comes down to 14 minutes. Yeah.
Mm-hmm.
But absolutely important, especially if your exam or assessment doesn't seem to correlate with what you're getting. At 4 minutes, the patient was placed on a non-rebreather at 15 liters and was given 120 milligrams of suppository Tylenol. At 14 minutes, another set of vital signs were obtained. Heart rate, pretty much the same. Temperature recorded at 103.8, and SATs are still 97%. End-tidal is documented at 100, and blood glucose is 243. The patient transport was initiated at 16 minutes, and the patient, upon loading into the ambulance, the one agency documented that there was tonic activity with right eye gaze and nystagmus, where the other agency documented that the eyes were not deviated. There was discussion about starting IV or not. They noted that the SATs had decreased to 89%, and an attempt at getting an IV was made at 27 minutes, which was unsuccessful. There was a discussion about trying an IO, but ultimately it was determined or decided upon that this will be deferred to the hospital once they get there in 3 more minutes. All right, so I'll leave this to Dr. Whitwer to discuss.
Okay, the good and the bad. Well, the good, everybody arrived. The bad, this was a chaotic situation, and actually outside the home, they had to go through a gauntlet of what apparently was described to me as gang members. So this was, kind of fraught with some excitement. What we had here, and if you can go back, I'm not sure where they documented that the seizure had stopped.
So this is documented that this, from my understanding of the documentation, that this continued in route to the hospital. The tonic activity, right eye gaze, and nystagmus.
This is a thing of an argument about interrelator observation, and I'm convinced after talking with the crews that at least the Vancouver crew felt that the seizure had stopped shortly after they arrived. The kid was actively seizing when they arrived, which, if you would argue, was probably because they didn't call 911 for about 5 minutes. It took 7-8 minutes to get there, plus another 2 minutes to get into the actual thing. So you got a child seizing for about 15 minutes, and he was seizing while they walked in, and then seizure stopped, and they felt that the seizure had stopped. They did not initially establish the temperature, because however the temperature was taken, it was taken with a non-contact thermometer, and probably from too far away, and it read it was afebrile, although the child was hot to touch, so that had to be rechecked. So then from that point on, the child is described as, by one observer, as having some eye deviation and perhaps some tonic activity, but primarily laying there quietly, not moving at all, staring straight ahead at time, mostly. And this was observed primarily by 3 trained observers. Now, the child is then transported. It's a rapid transport. It's only a few minutes to the hospital. No discussion was actually held between the crews. I have to say there was a bit of tension between the crews, but no one had the actual discussion of saying, "Hey, do you think this child is still seizing?" Or, "No, I don't think this child is seizing because of what," and let's discuss this. This is the first point that I want to make, in that you guys have all seen febrile seizures. Febrile seizures are generally over and done with by the time you arrive. If they're not, that is not a normal febrile seizure. And usually, what is the outcome of the fever subsiding? The child begins to wake up, is usually quite agitated and quite confused, apparently, and cannot usually be consoled by anybody except his mother. And that, so They're actively moving about. They do not lay there passively, looking straight ahead in this blank, almost like a absence seizure, a petit mal seizure, or if they're laying there and moving with tonic activity, or with um, or clonic activity rather, with a rigidity and with the eyes deviated to one side, that child is still seizing. And Jackie's going to talk a good deal about that. But that is not, so the normal response of a febrile seizure is when it stops, the child becomes postictal and begins waking up and is abnormal. At that point, they don't need to have the Versed. But if you at any point think that the child is having, is still in a seizure, that child needs Versed. And Versed it can be given IV, IM, or preferably IN in this case. You can also give it rectally, but we don't have the formulation for you to do that. Then there were other hints that this child was still seizing and that still maintained a heart rate in the 180s. Still, and then began drooling, and then began having a decrease in his O2 sats. So the issues were quite straightforward to me. This is, and I've done education with the crews already, that this was a child who was continuing to seize, and that's an educational thing. Now we're going to talk about, Jackie's going to talk about our protocol in a bit, and I want to go over that to see that everybody understands the protocol, or if it's confusing at any point, we're going to have to change it.
Yeah.
Go ahead.
And that's another point of like making sure that you're looking up your pediatric vital signs to know if they are abnormal. It's documented there was no tachycardia, but both heart rates are tachycardic for this age of child, which the upper limits of normal would be 160, and also this hypertension that was documented. So always good to verify your vital signs, even if you feel that they're probably that you think they're normal for the pediatric patient. Do you want to speak to any of these points, Dr. Whitwer?
The answer is Versed appropriate in febrile seizure? Yes, if the febrile seizure has not stopped, or if they're in status, or if they're in a complex seizure, which I think you're going to have a slide about.
Yes.
Is Versed and Tylenol appropriate if not febrile? Well, Tylenol is not appropriate unless they're febrile, and if Versed is given, you can give Versed to a status seizure, even if they're not febrile, because I mean, a large number of the seizures that you see are from chronic or from epilepsy, and they don't have to be febrile, and they still need Versed to stop it if their seizure is not stopping. In other words, if they're in status. Is Versed okay if Tylenol not given? Of course. Because Tylenol doesn't treat the seizure. If you're using Versed to treat the seizure. Will Versed mask seizure activity? No. Hopefully it will stop seizure activity. What masks seizure activity is paralytics. So Versed hopefully will stop your seizure. Now, in status seizure, it often doesn't, as Jackie will talk about as this goes down. What is considered status in pediatrics? Does it differ from adults? Not really. So I'm going to let you talk about that because you have the slides on that.
Perfect. Absolutely. So in the emergency room, the physical exam was significant for the deviation of the eyes to the right. The lips were pursed. There were rhonchorous respirations reported with a SAT of 88% and tonic-clonic activity of the extremities. An IV was attempted, it was unsuccessful, so they placed an IO. The patient received Versed times 2 doses. He also received fosphenytoin, which is an antiepileptic. He received antibiotics for concern for possible meningitis. And then he also received Keppra, another antiepileptic medication. So over his 104-minute ED encounter, he had 5 discrete seizure episodes with various presentations, not all like the initial physical exam reported. He also was determined to be COVID positive, and because of his needs, needing continuous EEG and his instability requiring multiple antiepileptics, he was transferred to Children's Randall Children's. There, he was admitted to the PEDS ICU for complex febrile seizures, status seizures in the setting of COVID illness. He had no additional seizure activity nor fever for the remainder of his hospital course. And both his CAT scan of his brain and the EEG looking for abnormal seizure-like activity in his brainwaves were normal. Neurology was consulted and they recommended discharge with rectal diastat, 7.5 milligrams to be given if he had a seizure greater than 5 minutes, and they recommended to follow up with neurology. Incidentally, they found that he had infections of the nail beds, they're called paronychia, on multiple digits, and they thought maybe this was MRSA related as he had family members that also had recurrent skin infections, so he was discharged with appropriate antibiotics for paronychia.
You should just clarify the diastat is rectal Valium.
Yes. It's the formulary that allows it to be rectal, but it's Valium.
It's a suppository.
Yeah. So febrile seizures. Oh, and I wanted to mention, because it was documented that the ED physician had said if the patient is not hypoxic, there's no need to give benzos of still seizing. That is hopefully quite apparent by the time we finish the next couple slides and the discussion that Dr. Whitwer's already talked about. And I also wanted to mention, I have a little note here that according to the Neurocritical Care Society guidelines, any seizure lasting greater than 5 minutes of continuous clinical and or EEG seizure activity. So any seizure lasting greater than 5 minutes or recurrent seizure activity without recovery is considered status according to the Neurocritical Care Society, specifically more of like both adult and pediatric. But I'm going to talk specifically here about febrile seizures in those present in our pediatric population. So febrile seizures occur when there's a sudden spike in temperature, usually greater than 38 degrees Celsius, without underlying seizure etiology or disease. It's specific to the individual. It doesn't have to be a certain number for their temperature to spike. It's really about how fast it happens for them, and that the febrile seizure might be the only thing that presents itself as the indication that the child is currently sick. They might, you might get a history that the kid was totally fine until he had this seizure or had this weird presentation. So that's not uncommon. Usually this occurs in 6-month to 60-month-olds, and of the seizures that occur, 4% are in this age group. The seizures that occur in pediatrics, 4% are in this age group. The pathophysiology is unknown. I know that I've had discussions with pediatricians that say that they believe it's like neuroprotective, is that as the temperature rises quickly, that the body compensates by having a seizure to try to cause diaphoresis and help dissipate that fever. It's not necessarily proven that is absolutely the case, but that's a speculation. And they do believe that there's a genetic predisposition. So families that have siblings, older siblings that have had febrile seizures, they believe that the probability of the younger children to have a febrile seizure is higher than if the siblings never had a history of febrile seizures. There's 2 types of seizures in febrile seizures. There's simple and complex. Simple is generalized, so tonic-clonic, lasting less than 15 minutes and does not reoccur in 24 hours. They return back to normal and you don't need to do an extensive workup. And oftentimes for us in the hospital, if they have a history of previous febrile seizures and it falls under simple, we don't do an extensive workup at all, and potentially even suggest that they don't need to present to the emergency room if that's an underlying history. But that makes it a little bit murky, so I don't want you to get too wrapped up with that. Complex seizures is any one seizure, or it has to have at least one of the following. So it has to be not generalized, but located in one particular area. So maybe extremity, one-sided. So focality has to last greater than 15 minutes and has to reoccur in a 24-hour period. So if it's not generalized, if it's longer than 15 minutes, or if it reoccurs in a 24-hour period, it's considered complex. And those patients absolutely require presentation to the hospital, labs, imaging, and further testing, likely admission, depending on discussion with specialists. So treatment for febrile seizures is that it's usually self-limited. Like we get there and they no longer are seizing. Antipyretics such as Tylenol or ibuprofen have not been shown to prevent reoccurrence of a seizure. I think a lot of times we think of it as just we got to do something, which is fine. Biggest thing is trying to dissipate the temperature for the child. So removing all of the blankets and jackets and clothing that they have to help dissipate that temperature for that child. And that benzodiazepines may be a bridging measure during a febrile illness. So it will help to decrease subsequent seizures if they had one. Let's see here. I have a couple notes. So according to the pediatric guidelines, febrile status seizures are seizures lasting greater than 30 minutes, and it occurs less than 10% of all first-time febrile seizures. So pretty darn rare, but in this case, this kid was a febrile status seizure. And that rectal diazepam is recommended if the seizure lasts greater than 5 minutes, which was also indicated for the discharge recommendations for this particular patient. Some people feel that intranasal Versed is helpful and some don't, but it's also an option to give. And I thought was interesting in my research for this presentation is that they recommend treating if the patient is still seizing, so not just because the kid had a seizure, but if the patient is still seizing, they recommend treating this child, not watching the kid have a seizure for a prolonged period of time, because it increases the chances of them developing mesial temporal sclerosis, which increases the odds of them developing epilepsy later in their life. So that we should not just watch them continue to seize, and that treating a febrile seizure because they're still seizing is just as necessary as treating a seizure of any other etiology. So according to our protocol, in pediatric patients that are seizing, if the patient is in status, so continuous seizure, repetitive seizure without regaining consciousness, we can also add greater than 15 minutes, focality. We're going to be giving Versed 0.2 mg per kg intranasal or 0.3 mg per kg intramuscular for a max dose of 5 milligrams, can be repeated every 5 minutes until the seizures stop. If an IV is available, the dose for Versed is 0.1. So again, another example of intranasal and IM is double the dose usually than IV or parenteral. Monitor the child's respiratory status, especially because Versed can lead to respiratory depression, and there may be some partial airway obstruction postictal for the postictal child. And then febrile seizures are generally found between the ages of 1 and 6 and usually short in duration. And if the fever is greater than 103 and seizing, so I would say that you're going to give Versed if the kid's still seizing. And if the kid has a temperature, you have the option of giving Tylenol. It doesn't have to be that they have to be febrile and seizing to be treated.
Correct. That's where I'm asking the group, I say, is this patently obvious or clear, or do we need to change it? Do we need to put under febrile seizures the exact same thing that we have in number in number A, which would be for a general seizure patient? Or is this adequate? Are people going to understand? Apparently they haven't understood it.
Before we move forward with that question, I just wanted to make one quick little clarification. In the current protocol version, our Versed dose for peds is 0.2 milligrams per kilogram, all routes.
Okay, thank you.
There's no variation based on route.
That's a good point. Again, that's because I can't download the most recent version, but I will fix that for future ones. I don't know. I think that maybe we can make an adjustment to that line that says a fever greater than 103 and seizing. I think if people believe that it has to be both in order to treat it, that obviously led to misunderstanding of what to do with this kid.
Well, we did make it fever. We did make it febrile seizure. And number A is basically counts for any status seizure. So
maybe
I have to change the status seizure a little bit to greater than, continuous seizure lasting more than 15 minutes or 10 minutes. I mean, I don't, and then maybe repeat the same thing down below.
I think that maybe put the if fever, you can put that under 2 and then make it like 2A, cool the kid and give him Tylenol.
Right.
Another quick suggestion, I think if we pull the seizure protocol into the next QA meeting and have the group discuss this, I think we'll just send this out as this square that we have right here, send that out for feedback. I think that would make a lot of sense. But I think getting a little bit more QA feedback on that would be helpful as well.
Yeah. It sounds reasonable.
And also then just to make the point is that, and if you're not, well, 2 points is that I expect that the crews will discuss these things between themselves as they're dealing with the patient. And by and large, that I'm very pleased, by and large, that has occurred almost universally in the county. And I think it is definitely getting better, but there are always some differences, just like there are differences between Dr. Gadbois and I and on our approaches to things. And and within the emergency department group, there's several differences of opinion, but when there are differences of treatment on a specific patient, that's where it counts, where it really helps to have everybody working as a team and to discuss how to do this and to come up to and to come up with the approach that you're going to use on that patient. The next thing is remember if you're not 100% convinced that this child is still seizing, knowing that I want you to treat a seizure, that it is not good for the child to continue to seize. You're always better to err on the side of giving the Versed, because what is the downside? There is literally no downside except for being aware of respiratory depression and being ready to manage that, and suction, etc., the normal kind of things. You're paramedics, and so you can manage that sort of thing. But the downside of having a continuous seizure is much greater than that. So, you have to weigh harm versus benefit when you're doing anything.
Absolutely. Well, couple of just quick review that if there's this picture basically shows you both the venous, capillary, and arterial system. There's a lot of blood vessels. When we have injuries or issues with the pathophysiology of our blood vessels, it can manifest itself in a variety of ways. And remember, in the dissection case, they're not always chest pain or back pain. They can present as shortness of breath, acute heart failure, strokes. In patients that you're dealing with shortness of breath, make sure you look at your vital signs and take the larger picture into consideration on management of the patient. Sometimes you can walk down both routes if you're going to do bronchodilators and managing the patient with CPAP and working on trying to lower their blood pressure. But if you're not for sure, you always can contact medical control. Ketamine, we're really looking at treating pain and sedation or induction. So 0.3 mg per kg for pain, IV, and then 2 mg per kg for induction and maybe a change in the sedation protocol, post-intubation sedation protocol to come. In that we're not using two indications and combining them for a megadose. Lastly, pediatric seizures. In regards to febrile seizures, we are treating them if they're still seizing with appropriate antiepileptics, which in our arsenal is Versed. We're managing if they're febrile to, at minimum, reduce the temperature by environment, and then option for Tylenol. And it doesn't have to be febrile and seizing to manage the patient. List of references used for this presentation, and that is all I have. So if no one else has any other questions, thank you for your time. Sorry we went over, but I think that these were good cases to discuss.
Thank you, Jackie.
Yeah, absolutely.
Well done. Thank you, Dr. Gabois.
Absolutely.